Hi, everyone. My apologies for getting this presentation up a day later than I told you I would at the beginning of the semester, but I guess better a day later than several days. So I'm going to start with the chapter that we read this week on psilocybin. So as we read, there has been and what we covered in week 2 was a really long history with plant-based psychedelics in particular, with psilocybin having one of the longest histories. So the earliest documented report of human use of psilocybin mushrooms was in 1502 during the ritualistic coronation of Montezuma II. So in several Central American countries is where we know psilocybin to be used more predominantly. Then the Spanish Inquisition happened, and individuals from other countries came in to these indigenous cultures and in many ways vilified their way of life, their rituals. So they waged a holy war against indigenous psilocybin use, considering it hearsay and devil worship. The Spanish conquerors seized and destroyed artifacts and books depicting mushrooms and suppressing sacramental mushroom use. So as we know, there's lots of historical symbols and writings and of psilocybin use. So many of those artifacts were destroyed. Indigenous practitioners and shamans were tortured, and their practices were hidden from Spanish conquerors for 4 centuries. However, despite the suppression, fungi were portrayed in surviving portraits and artifacts from the Spanish conquest, and ceremonies involving mushroom consumption were held underground in caves by Mayan people for healing and acquiring knowledge. So, the Mayan people doing what they can to keep their history. So the first medical report of use of psychedelics or psilocybin in particular was in 1799 by Dr. Everdadd Brandy, who reported the first reliable account of a psychedelic mushroom intoxication in the medical literature. And remember, intoxication just really means that you're feeling the effects of something. So this is no different than what we talk about with the psychedelic experience. So a British family in London experienced visions and hysterical laughter after ingesting wild psilocybin-containing mushrooms, and these mushrooms are later identified as Psilocybe celamanciata. And Dr. Brandy's report provided valuable insights into the effects of psychedelic mushrooms, and we know much more now. So then Richard Evans Schultz and Wasson's rediscovery of psilocybin in the 1930s through the 50s. So, 150 years later, an ethnobotanist named Dr. Schultz reignited scholarship in psilocybin in the late 1930s. He conducted a systematic anthropological research identifying a unique mushroom specimen used in Mexican Indian tribes. And Mr. Wasson, an investment banker, and his wife, Dr. Valentina Pavlovna Wasson, continued Schultz's work in the 1950s. The Wassons made multiple trips to Mexico, discovering Psilocybe mexicana and experiencing ceremonies guided by Mazatec shaman Maria Sabina, who we talked about, I believe, in week 1. So if you want to review any of that, she was very briefly mentioned in this chapter, but she has there's a lot more information about her in earlier readings from the semester. And so Maria Sabina invited the Wassons to a traditional ceremony and really showed them what happened. And then the mushrooms were provided to the Wassons, taken back to Dr. Schultz or Schultes, and he was able to identify part of the he identified part of the active ingredient, but wasn't completely able to put his finger on it. And then Mr. Wasson detailed his discoveries in an article in Life magazine, and this is really what sparked lots of interest in psilocybin in particular in the 1950s. So then Albert Hofmann and Sandoz Pharmaceuticals, again, I talked about this in the timeline, I believe in week 3 for this class. So Robert Heim sent samples of psilocybe mushrooms to chemist Albert Hofmann for chemical analysis. Albert Hoffmann's a Swiss chemist who was actually able to extract both the compounds of psilocybin and psilocin. And Hofmann was able to synthesize psilocybin and provide that to Sandoz laboratory. And Sandoz, he synthesized this, or continue to synthesize and produce psilocybin, and made it freely available to any researcher who wanted to test it, for no charge, to my understanding. And they so this eliminated the need for mushroom cultivation. So pure synthetic psilocybin pills were made under the name Indocybin, and they were distributed to physicians and researchers worldwide, really exploding the study of psilocybin. So Sandoz produced 2 other synthetic drugs derived from psilocybin, CZ74 and CEY19. These compounds had shorter durations of action compared to psilocybin. This was a 3-hour action period as opposed to the 6 to 8 for pure psilocybin. And there was, as we know, political backlash in the United States, and this led to the recall of psilocybin by Sandoz in 1965. In 1962, Hofmann bought synthetic psilocybin. He brought it to Maria Sabina and had her try it. And she said that she experienced no perceptible difference between the synthesized psilocybin and then ingesting mushrooms on its own. However, if you think about, the spiritual component of this was probably felt as though it was missing from Maria Sabina, because it's one thing to like take something from the ground and believe in the wisdom of the earth and animism and all of these components that we learned about earlier in the semester, and then have it just reduced to the active ingredient from the mushroom. I'm sure that even though her experience may have been no different in terms of her perception, and what she was experiencing in terms of visuals and all of that, that the spiritual component was potentially missing. And then the discoveries and research during this period laid the foundation for further exploration and understanding psilocybin, but there was not a big gap, but about a 40-year gap between when the war on drugs happened and the resurgence, kind of the wave that we are currently in with psychedelics. So psilocybin is a hallucinogenic tryptamine found in psilocybin-containing mushrooms. It's considered a prodrug, which rapidly converts to psilocin in the intestinal mucosa and the liver. Psilocybin is converted to psilocin in the body. Psilocin is the main psychoactive and psychedelic substance in hallucinogenic mushrooms. Psilocin undergoes oxidative metabolism and glucuronidation in the body. I looked up what that was, and it didn't make any more sense to me. It's like converting to glucose. I think. So feel free to look that up and be a little clearer on that. So the half-life, so what a half-life means is the time it takes for the amount of the drug's active substance in your body to reduce by half. So the half-life of psilocin in plasma is approximately 2 to 2.5 hours. So that's how long it takes to reduce the active substance by half in the body, with their effects of the psilocin lasting 6 to 8 hours, which we've covered. So the mode of administration and dosage, how psilocybin is used. Psilocybin mushrooms are typically consumed orally, either eaten as raw mushrooms, dried mushrooms, brewed as a tea, or cooked in other foods to try to limit some of the bitterness of the taste of psilocybin or psilocybe mushrooms. The minimum amount for desired psychological effects is around 1 gram of dried mushrooms or 10 grams of fresh mushrooms. So it is always a 10-to-1 ratio of what is needed fresh to dried. Recreational doses range from 1 to 5 grams of dried mushrooms and 10 to 50 makes sense, 10-to-1 or 1-to-10 ratio, however you want to organize it. And the individual metabolism of an individual's metabolism really does play a role in the person's response to psilocybin. One of the things that we read about, I believe last week, as well as in some of the chapter here, that metabolism plays a role, but also the food that you have in your gut plays a big role in this. So in all of the randomized controlled trials that are taking place using psilocybin for various applications, one of the pieces of information that we give our participants is to make sure to eat a fat-free diet, essentially, for preferably 24 hours prior to drug administration, because any of the fat that's still lingering in your intestinal tract, which is where the majority of your serotonin receptors are, really can dampen the effects of the psilocybin experience or really delay the effects, which can be scary. I don't think I've told you all this story before, but we did have one participant in our study who I believe had like biscuits and gravy or something for dinner the night before and didn't disclose it to us until like after the administration. So even when we asked, what did you have? I don't remember having anything. Oh yeah, I had biscuits and gravy. So lots of dairy, lots of cream, lots of fat in that meal. And they actually didn't start feeling the effects of psilocybin for over 2 hours. And as we've read in this, it takes about 20 to 40 minutes to start to, I think it's in actually the next slide, 20 to 40 minutes to feel the effects of psilocybin. And for our study and many studies, there isn't an overnight component. So you're basically in the unit, whatever setting that you're in for the day. And then we would always either drive the participants home or make sure that we like physically transferred them to a trusted other person who would take them to their house. And so that was planned for about 9 hours post drug administration, because we would have them do some questionnaires and surveys immediately after the experience. And so they would be in a sober state of mind or very much coming down. And so by the time our time had ended in the unit, this participant was definitely still tripping. So these are some things that are like ethical considerations, just logistical considerations. So we took this participant home and she was still experiencing like macropsia. I think that's how you say it, where things look bigger than they are. Sorry, I gave away the gender, was looking at her hands and was like, whoa, my hands are so big. So that's another reason to really have some understanding of how different psychedelic substances react with different seemingly, innocuous or benign components or compounds kind of already existing in the body, like fat. Not necessarily like body fat composition, but just like fat that's in your digestive tract. Then the concentration of psilocybin in mushrooms varies, so dose ranges should be interpreted cautiously. Again, this is another reason why taking mushrooms and just kind of plucking them from the earth or eating them dry is very different from having synthesized, because synthesized, you can really control how much of psilocybin is in the capsule, where you don't know what the concentration is in different mushrooms. So you could eat 2 different mushrooms and have 2 very different experiences from that, because the concentration of psilocybin can be very different. All right, so pharmacokinetics, how psilocybin is processed. It is rapidly dephosphorylated. Again, it's a phosphorate type process. This is not my area of expertise, but if you go to any sort of other specialty, they would know exactly what that means. So basically, though, the psilocin, when the psilocybin is converted to psilocin in the body, it is comes into the intestines and liver before entering into the central nervous system, and it is excreted through the urinary tract system. So it becomes psilocin is the main urinary metabolite, which is again glucurinated, created into glucose, and then excreted through the kidneys. And so psilocin undergoes oxidative metabolism, producing metabolites like 4-HIAA and 4-HT. I'm just giving you information. I cannot clarify that any further than what I did here. And the onset of the psychoactive effects typically occurs within 20 to 40 minutes of oral administration if you have an empty digestive tract. And the elimination of psilocybin and psilocin occurs mainly through the kidneys within approximately 24 hours. So there would be no trace of any of having taken any psilocybin 24 hours after ingesting it. Another mode of administration for psilocybin is intravenously. That has been used in research, but it's a very different effect than orally, and in many ways much less powerful or punctuated, mystical, because what we're learning is the best means of administration of this is orally, which in many ways makes sense because it's a mushroom that's meant to be ingested. So trying to dilute it, make it into like a liquid form that can be taken intravenously, it makes sense that just like wouldn't be ideal. Okay, so psilocin has a high affinity for serotonin receptors in the brain, which we know it is primarily acts as an agonist or an upper, amplifier of serotonin 5-HT2A and 2C, as well as 5-HT1A receptors. So just really working on the serotonin system. Activation of the 5-HT2A receptors is crucial for mediating psilocin's subjective effects. So that's what we know in terms of what receptors are primarily affected. And it allows us to understand through qualitative research, also through some quantitative research, what exactly these receptors do. And it interacts with other serotonin receptors, a bunch of different HTs, and then modulating serotonin receptors is clinically relevant for the treatment of psychiatric disorders such as depression and anxiety. So as I'll talk about a little bit later in this presentation, depression and anxiety are also treated with ketamine. However, with ketamine, you have to take the substance more often, and because the effects only last a few days to weeks, whereas with psilocybin, it can last months with stronger effects. So there's also dopaminergic effects. So psilocybin indirectly increases dopamine concentrations in the striatum. And this is just for a definition of that, it's a cluster of interconnected nuclei that form a part of the basal ganglia. It is involved in decision-making functions such as motor control, emotion, habit formation, and reward. So that makes sense. However, it's a really dulled effect. So if you think about emotion, habit formation, and reward, that is also what makes psilocybin have a really low abuse potential, because the reward system is not activated. So psilocybin is not typically considered a drug of addiction, as they're not capable of producing sufficient reinforcing effects to produce addiction. They engender rapid tachyphylaxis, which means that you build a tolerance for it very quickly. So psilocybin can also produce unreliable experiences that may be profoundly unpleasant and frightening. They are not, psilocybin is not known to have any withdrawal syndrome. And so therefore psilocybin is very rarely used on a daily basis. And that doesn't normally lead to any sort of compulsive drug seeking behavior. Also, there's no connection to dopamine, which is one of the most addictively reinforcing neurotransmitter systems that we have in the body. So the dopaminergic system contributes partially to the psychological effects of psilocin, but it has no affinity for dopamine D2 receptors, and only about 30% of psilocin-induced symptoms are reduced by a non-selective dopamine receptor antagonist. So that just means that about 30% of psilocin-induced symptoms have anything to do with dopamine. Because remember, a dopamine receptor antagonist means that it dampens or tries to shut off the uptake of that. So it also has glutaminergic, it works on the glutaminergic system, and we know a little bit about neuroplasticity in terms of increasing neuroplasticity. Okay, so the activation of the AMPA and the NDA receptors on cortical pyramidal neurons contributes to increased expression of brain-derived neurotropic factor. So pyramidal neurons in the prefrontal cortex are implicated in cognitive ability. In mammals, the complexity of pyramidal cells increases from posterior to anterior, posterior, anterior brain regions. The degree of complexity of pyramidal neurons is likely linked to the cognitive capabilities of different anthropoid species. Pyramidal cells within the prefrontal cortex appear to be responsible for the processing input from the primary auditory cortex, primary somatosensory cortex, and primary visual cortex, which all process sensory modalities, which makes sense as to why you are hearing, seeing, and also feeling differently within a psychedelic experience, particularly with psilocybin. These cells might also play a critical role, so these pyramidal neurons, in complex object recognition within the visual processing area of the cortex. Relative to other species, the larger cell size and complexity of pyramidal neurons, along with certain patterns of cellular organization and function, correlates with the evolution of human cognition. So in some ways, this really makes sense in terms of how it increases neuroplasticity. And then when we're thinking about, remapping or rebuilding the roadmap, or being willing to kind of go off of this predetermined roadmap, how the pyramidal neurons within the prefrontal cortex can be, them being affected can make sense in how that happens in psychedelic experiences. So decreased levels in neurotrophic factors have been associated with stress and depression, which is one of the places where psilocybin can be helpful. Psilocybin, similar to other antidepressants like ketamine, enhances neuroplasticity and may offer a novel approach to mood disorder treatment. And as we read later in the chapter, it's being tested specifically with major depressive disorder in particular. So some therapeutic effects. Hopefully this will be quite a bit of review for you. Psilocybin shows promise in producing rapid antidepressant effects, also anxiolytic effects, which means a reduction in anxiety. It may share a common mechanism of action with ketamine, modulating the glutaminergic neurotransmission of the prefrontal limbic circuitry, which we know prefrontal limbic circuitry is like top down, but the leveling out of the brain allows for new pathways to be created and potentially even upheld. So psilocybin induced antidepressant effects may last several months after a single dose, whereas with ketamine, that's how in terms of an antidepressant effect, the two are differentiated by psilocybin having a longer, I don't want to say active period, because that usually means active in terms of like intoxication, but those residual effects of these residual antidepressant effects last longer, where, like I said, ketamine tends to be at most a 2-week effect. So further research is needed to explore the therapeutic potential of psilocybin in the treatment of depressive spectrum disorders, which is happening right now. Psilocybin causes sympathetic arousal. So in terms of physiological effects, dilated pupils, increased deep tendon reflexes, mild to moderate increases in respiratory rate, heart rate, blood pressure, and body temperature. Some more uncomfortable side effects that can happen: headache, dizziness, tremors, weakness, yawning, nausea. Again, with serotonin receptors being in the gut, that makes sense. Anorexia, muscle aching, shivering, restlessness, arousal, sweating, abdominal pain, dry mouth, sleep disturbances, impaired motor coordination, and working memory. Though those are extremely rare. So in like the millions of doses that have been given, this has happened like a handful of times. So the likelihood of having something more serious like impaired motor coordination or a difficulty with working memory, those in many, I don't want to say they're necessarily isolated incidences, they're just extremely rare. So psychological and subjective effects, we talked a lot about this last week, but some significant alterations in perception, so visual and auditory illusions or hallucinations, though that label on what you're seeing is up for debate. As we know, that would be a hallucination, would be something a shaman would never describe happening, because it is in many ways an ability to see things that other people just aren't able to see. And then synesthesia, which we know is like the crossing of senses, so being able to smell colors. Changes in cognition, tangential thought processes, dissociative phenomena that can happen. In some ways, this is highlighted by things like a loss of a sense of space and time. So just feeling kind of like you're in a little bit of a void, but it more so feels euphoric because there's this oceanic boundlessness that you can experience. It affects mood. So there's mood fluctuation ranging from euphoria to extreme anxiety. And this is usually what the extreme anxiety is, what is colloquially known as a bad trip, but it can really be mitigated in controlled settings with a trusted guide. So usually you have a bad trip when you are in a non-supportive setting, and potentially with like unsafe people, or with people who just like don't know what to do with you when you're in that state. And then these effects, cognition, perception, mood, these are all influenced really significantly by set and setting, and then dose and route of administration, like we talked about last week, make a big difference in that as well. So big range in experiences, positive spiritual and mystical type experiences are predominantly what qualitative data has shown us, and in some ways anecdotal narratives about this has told us. And so there's positive changes in affect, cognition, and behavior, all the like on a spectrum to unpleasant experiences dominated by dysphoria, fear, and psychotic like phenomena. So remember in many ways, the origin of psychedelic use was to be psychomimetic. So thinking that there was an ability to mimic a schizophrenic state. So we've talked a little bit about this, but I'll just say a little bit more here about some of the measurements that are used for altered states of consciousness, which is what somebody is in when they are experiencing the effects of psilocybin. The mystical experience questionnaire, these are all very commonly used in research with psilocybin in particular. So this measures core characteristics of the mystical experience, including feelings of unity, transcendence of time and space, which is that time and space have no meaning, noetic quality, which is a sense of encountering ultimate reality that is more real than everyday reality, sacredness, which is a sense of what is encountered is holy and sacred, a positive mood like joy, ecstasy, peace, bliss, tranquility, awe, ineffability, which is the experience is difficult to put into words, and paradoxicality, which is the coexistence of mutually exclusive states or concepts. And the AZP, or the 5-dimensional altered states of consciousness questionnaire, these measure altered states of consciousness induced by psilocybin, including oceanic boundlessness. So in many ways that parallels the transcendence of time and space. Anxious ego dissolution, so that ego death, dissolving of the ego that may not be serving you, is usually an extremely beneficial experience with psychedelics. Visionary restructuralization and acoustic alteration, so you're hearing things a little bit differently, and vigilance reduction, so in some ways inhibitions are lowered. And vigilance, you can think of this in terms of like vigilance with trauma, that there's a reduction in that. Psilocybin-induced mystical experiences associated with positive change in attitudes and behavior and partially mediate therapeutic effects in the treatment of cancer-related psychiatric distress. That was one of the studies that we read about specifically. We read an article about that this week that I will talk about in more detail with you. So some potential adverse effects, so safety, psychological side effects, toxicity, and lethality. There are low levels of medical toxicity associated with psilocybin in animal studies. Psilocybin occupies the least harmful end of the spectrum among psychoactive substances. I showed you nuts and associates, or Nutt and Associates study from 2010, where they measured or quantified the harm of several substances. There has been no major organ system damage. Carcinogenicity, which is substances that are defined as carcinogenic, are at after inhalation and ingestion, dermal application, or injection, they induce malignant tumors, increase their incidence of being malignant, or they shorten the time of tumor occurrence, occurrence, so it will happen faster. And then tetragenicity is the ability of a drug to cause fetal abnormalities or deformalities. So if you remember from previous presentations, tetragenicity was one of the main like myths about psychedelics, is that they've caused abnormalities of fetuses in the womb, or overdose deaths reported. So there's been nothing in the history of this. Transient increases in blood pressure and pulse may pose a risk for individuals with serious cardiovascular conditions. Being hypertensive is one of the disqualifying at this point criteria. So individuals who meet criteria for hypertension are not able to take part in any psychedelic studies. And psilocybin is not known to cause direct neurological damage. So it's really pretty safe. So psilocybin administration in clinical trials, there's been over 1,000 doses of psilocybin administered safely in research settings. No reports of SAEs or serious adverse events or treatment-related serious medical toxicity. No reported cases of prolonged psychosis or hallucinogen persisting perception disorder, also known as HPPD. In many ways, I don't know how much I agree with that diagnosis anyway. Careful attention to screening, setting, dose, preparation, and integration is a huge piece in the clinical trials. So again, screening, super important. It's very thorough. It's not only a potential participant report, but participants meet with physicians to have their blood drawn, have a bunch of vitals taken, a thorough history taken. So the screening process is really thorough. And then of course, setting is paramount in terms of the experience. Dose is between 20 and 30 milligrams of psilocybin per 70 kilograms of the person's weight. We use 25 in our study, and integration, going after the drug administration and saying, what do we do with this newfound insight? So potential adverse effects: psychological distress. Acute adverse psychological experiences are things such as bad trips, like I talked about. These are generally exacerbated in sets and settings that are not ideal. So bad trips you can experience anxiety, panic, dysphoria, depersonalization, so you're feeling not real, paranoia, agitation, fear. The list can go on in terms of just negative affective experiences. This is more likely to occur in recreational settings with unprepared individuals and psychological risk factors. So again, if you're like kind of prone to anxiety and you're a little anxious about taking psilocybin, that's likely going to be exacerbated in your trip. High doses of psilocybin can still cause transient episodes of anxiety, dysphoria, extreme fear, or psychotic-like reactions. We have had in the study that I've been a part of, participants who started crying, who were very scared, weren't quite sure why, but that's why the preparation is so important, because we formed a trusting relationship, and all we really had to do to intervene was, gently touch their shoulder and remind them that they're safe, they're okay, that this is temporary. If there's anything scary, to go through it, remember the mantra, trust, let go, be open. Difficult experiences can often have a positive therapeutic valence, which is what we also encourage them. If there's something you're seeing, move toward it. There's probably something that you need to know about that, or that might be helpful for you in uncovering. And also remember, these are individuals with substance use disorders, where they've likely detached from many of these scary experiences through use. So let's go toward it, so the substance that you're using doesn't seem as necessary. So some psychosis in terms of induction of psychotic-like states with psychedelics, particularly psilocybin. Psilocybin administration can induce a psychotic-like state resembling aspects of acute and emerging stages of schizophrenia. This is usually temporary when you're under the effects. A small percentage of participants may experience acute psychotic reactions, again, persisting for a very short period of time, if at all, after the active period of the substance. Reactions are managed through interpersonal support without pharmacological intervention. So for individuals who may experience HPPD, that they can get some supportive psychological interventions like CBT, and no long-term impairments of functioning reported in any follow-up studies that have been done. So then HPPD, hallucinogen persisting perception disorder, is a possible adverse effect of psilocybin. This is an uncommon disorder characterized by visual disturbances reminiscent of psychedelic use. There are two types: type 1, which is brief re-experiencing, and then type 2, which is more chronic. Type 2 is extremely rare. This is more likely to occur in individuals with chronic hallucinogen use, use of other substances, or co-occurring psychiatric illness. So in many ways, it's a combination of many factors coming together. Prevalence is rare, especially with careful screening and preparation in research setting, and there is no association between lifetime use of serotonergic hallucinogens and HPPD in population studies. So I'll talk a little bit more about those. There's been some secondary data analyses that have been done, which is kind of what would be considered naturalistic hallucinogen use, and there's no association that is known with that. So evidence-based clinical applications for psilocybin therapy, we're in this current wave of psychedelic research. So as we know, in the 1990s, after at least 2 decades of essentially underground research and a complete lack of federal funding, in the 1990s, this came back. I believe Dr. Grob was the first, and Dr. Doblin started the resurgence of this. Psilocybin research on human beings began in the late 1990s, focusing on the neurobiology of schizophrenia. So we kind of went back to our roots a little bit. And we're moving away from that, stepping back into it a little bit now, more recently, over 30 years later. Translational research projects explored the therapeutic potential of psychedelics within psychiatry. So this was in the early 1990s. And clinical trials with psilocybin, recent clinical trials are investigating the effects of psilocybin in the treatment of psychiatric illnesses, such as treatment-resistant depression, anxiety, end of life anxiety, OCD, addiction, all the addictions are being covered in some way, shape, or form. Completed trials are open label or randomized control trials. So open label means that both the participants and the researchers know what the treatment is. So it can be both open label and double blind, meaning that we know what the substances are. So ours is open label. Participants knew that they were either getting psilocybin or diphenhydramine, but it was double blind because we didn't know who was randomized to each condition. Okay, and then so another thing here that I want to note, in the notes of this slide that you have access to in Google Drive, I put the link to clinicaltrials.gov because at the publication and dissemination of this study or this book, it stated a lot of like, this study should be completing data collection in like July of 2021. But clinicaltrials.gov is where you can go, and what I did was I searched psilocybin. You can see all of the clinical trials that are using psilocybin all over the world that have registered with clinicaltrials.gov, which is a best practice. So they all should be registered there. And you can see what state they're in, meaning like what stage that they're in. Are they actively recruiting? Have they completed? Are they in data collection? Have they completed and are analyzing results? Have they stopped recruitment for whatever reason? So I did put that link here because some of these projected end dates are not accurate. Okay, cancer-related psychiatric and existential distress. Again, we read more thoroughly on this week. But with cancer-related disorders, clinical trials are focusing on treating psychiatric disorders in patients with advanced and terminal cancer. There have been 10 published trials totaling 455 participants investigating the use of LSD, psilocybin, and DPT as psychedelics for this. Psilocybin trials are showing promising results in reducing distress in cancer patients, increasing their quality of life, decreasing anxiety about dying, which is a big deal. It's definitely the psychological distress of a cancer diagnosis or of a terminal diagnosis does not get enough attention in our field of mental health. So RCTs are being conducted at UCLA, New York University Langone Medical Center, and Johns Hopkins University Medical Center that are all following similar methodologies. These are double-blind designs with active placebo. So ours was diphenhydramine. Niacin is another popular, common active placebo, which just means that they get something else. A non-active placebo would be like a wait list control or a crossover study with one group not receiving any sort of intervention, but like check-ins. And then validated outcome measures, so like the MEQ, any sort like the BDI, all these different quantitative measures. And then single, moderate to high dose oral psilocybin is administered along with psychotherapy sessions, like a minimum of 6 hours of preparation and usually a minimum of 6 hours of integration. So UCLA and the NYU trials, UCLA is a crossover trial, meaning that, so here psilocybin and niacin, so they're randomized to a group where either you're in group one that gets psilocybin first and then niacin, or you're in group two, which gets niacin first, then psilocybin. That's what crossover means. This is with terminally ill cancer patients and their psychiatric disorders. And then has been shown to be a significant decrease in STAI traits. So it's like state, anxiety, trait, and depression, Beck's depression inventory after psilocybin sessions. And then the NYU trial, this is also a crossover trial with 29 participants. They're smaller because these are phase 1 or pilot studies. So phase 1 studies have no more than 50 participants in it. Our study at UAB has an N of 40. And then with the NYU study as well, psilocybin produced rapid and sustained improvements in depression and anxiety symptoms, which is a big deal. All right, so Johns Hopkins University Medical Center trial. This is a large study with 51 participants with life-threatening cancers and mood or anxiety disorders. They were given a high dose and a low dose of psilocybin sessions. High dose sessions showed substantial and sustained improvements in anxiety and depression. Low dose tends to not necessarily promote that kind of change because it's more like microdosing. Then in terms of safety and efficacy, there's been no medical or psychiatric serious adverse events or SAEs reported in any of the trials. Psilocybin demonstrated clinically significant anxiolytic, and antidepressant effects. So anti-anxiety, antidepressant effects. And I wanted to say something else about that maybe. Okay, psilocybin-induced mystical experiences correlated with therapeutic outcomes. So if they had a mystical experience, then they had more desirable outcomes in terms of less anxiety, less depression. So there is a correlation that is being built between the mystical experience and in some ways like the intensity of that mystical experience and the outcomes in terms of anxiety, depression, use in terms of addiction. So we're finding that correlation is being built. Yeah, and I can't remember what else I was going to say. Maybe I'll say it later. Okay, so addiction with tobacco. So Matthew Johnson was the first to investigate psilocybin-assisted psychotherapy for tobacco use disorder. This was an open label with an N of 15, so small, just like, again, everyone's aware of what the treatment is. And participants received moderate to high doses of psilocybin over a 15-week treatment period. My understanding is that this was not a controlled, this didn't have a control group. So everybody received, all 15 received psilocybin, and 80% of participants were abstinent at 6-month follow-up. 67% of participants were abstinent at 12-month follow-up. And then that increased again to 75% of participants being abstinent at 2.5-year follow-up, which if you think about abstinence rates, particularly with tobacco, this far exceeds any of the going rates for current addiction treatment. There's an abstinent rate of less than 30% with traditional forms of addiction treatment. Okay, and then alcohol, LSD treatment for alcoholism started in the 50s and showed mixed results. In many ways, that does have to do with some of the methodology. Meta-analyses of 6 randomized controlled trials showed significant treatment effects of LSD therapy for alcoholism. Oh, this is what I wanted to say, that clinically significant means a 50% reduction. So that's a big deal. So whenever you see something that has clinically significant whatever, it means that there's an at minimum 50% reduction. So in 2015, psilocybin coupled with motivational interviewing showed improvements in alcohol use disorder. However that is defined. Significant reductions in abstinence occurred after receiving the first dose of psilocybin. We're playing around a little bit with dose in terms of, do we do one big one? Do we do 2 big ones? Do we do 1 big one followed by 2 smaller ones? Do we taper the dose? So we are still playing with dose. Overwhelmingly, the research shows that first administration, that first experience is the most meaningful and is correlated with the largest change. And there is currently an ongoing RCT comparing psilocybin to an active control for alcohol use disorder. All right, cocaine. Here was the study. Here's my study. So this is what we did at the University of Alabama at Birmingham, which for those of you who are not familiar, University of Alabama is in Tuscaloosa. They're the red team, whatever, the Crimson Tide. I was a Auburn fan in Alabama, but forever a Michigan State fan. And then University of Alabama at Birmingham is in Birmingham, and they are within the system of University of Alabama, but they are a completely separate entity. So just a frustrating typo all the time is that my mentor is always he's always reported as being at the University of Alabama, which he is not. Okay, so anyway, just a little tangent there. So this is the first ever trial examining psilocybin assisted treatment for cocaine addiction. We conducted a randomized control trial with 40 participants comparing psilocybin and an active control, which is diphenhydramine, large dose of diphenhydramine. So that's essentially Benadryl. So our participants got to take a really nice nap for those who were in the control group. Preliminary analysis. So what we did was we unblinded the first 10 participants, 6 of whom received psilocybin, 4 of whom received diphenhydramine. And this suggested a reduction in cocaine use and functional impairment with psilocybin. For any of you who are interested in that, if you Google like Peter Hendricks or my name, Horizons Conference 2018, you will see the results of those first 10 unblinded participants. So this is also a unique study because it's a completely different population or sample, I guess, than other studies. So the majority of our participants were low income or very low income African Americans who are very largely underrepresented in the research. The majority of research with psychedelics is generally more higher SES, white participants who I think are largely like educated, meaning like a minimum of like an associate's. And that is also not the case in terms of education being another factor that was different for ours. So that is a part of this study that we're really proud of in terms of having representation that's different than what is primarily informing psychedelic research. And another thing that makes this unique is there's no FDA approved medications for cocaine addiction. So this would be like the first pharmacological treatment for cocaine use disorder. So with opioids, this is one that there's been a lot of hesitancy to touch this. So clinical trials investigating psilocybin treatment for opioid use, they're in some ways finally underway. It was the last one because overdoses with opioids is so, it's such a possibility that we've been hesitant to touch it as a field because it could easily be, the narrative could be spun to be like, see, psilocybin killed this person. So the first trial is currently underway at University of Wisconsin-Madison, exploring safety and potential efficacy. So a pilot study. And then of course, there's a need for new and effective pharmacotherapies given the opioid epidemic. All right, so with MDD, there is an open label pilot study that has shown significant decreases in depression scores after psilocybin treatment. Improvements in depression scores maintained at 3-month and 6-month follow-up. These are two very common follow-ups, 3 and 6 months. So treatment time in total in studies tends to be 9 months, with the final follow-up being 6 months post completion of all of integration as well. Okay, so comparative efficacy trial comparing psilocybin to, let me try here, citalopram. This is a medication used to manage and treat major depressive and generalized anxiety disorders. So comparing an active, like another treatment instead of an active placebo. And then RCT at Johns Hopkins has 24 participants that is expected to be completed by the end of 2020. I do not know the status of that. I think they're still recruiting. Just some of these studies are very difficult to get numbers because the exclusion criteria are it's such a long list. So again, you can go on clinicaltrials.gov and see if that study at Johns Hopkins is still going on. All right, OCD, there's a double-blind clinical trial that has shown potential efficacy of psilocybin for OCD, but placebo effect is possible with that. Just knowing that you're in a study and getting the possibility of receiving psilocybin can improve symptoms. There are 2 ongoing RCTs investigating psilocybin's therapeutic effect for OCD at Yale School of Medicine. There's a study with a parallel design and fMRI assessment component. So parallel design just means that there are two different interventions happening at the same time. University of Arizona is 3 arms, so there's 3 different treatments that are being compared to one another. fMRI, the best imaging that we have for seeing activity in the brain, and the expected completion dates of this are July 2022 and 2021 respectively. I believe they're still ongoing. I believe they're still recruiting. So the Concord Prison psilocybin experiment that was done between 1961 and 63. This investigated the efficacy of psilocybin administration in group psychotherapy sessions. And the goal was to reduce recidivism in prison inmates by diminishing antisocial behavior. And this enrolled 32 inmates who underwent psilocybin facilitated group therapy session. Timothy Leary said it was like a smashing success, but it really wasn't upon like further methodological investigation and analytical investigation. So recidivism rates in the psilocybin group was 32% compared to base recidivism rate of 56%. But if you remember in the reading, the base rate was like predicted to be or assumed to be like twice as long as it actually is. And so he claimed to have kept twice as many convicts off the street, but a calculation was based on a recidivism rate that was questionable and having methodological flaws as well. And then using a comparable assessment time point, which reduced the like baseline recidivism rate, found that there was actually no difference in recidivism rates. And then Rick Doblin did a 34-year follow-up here. So he conducted a follow-up. He evaluated recidivism rates for parolee violations and new crimes at 2.5 years post-release. Recidivism rates at 2.5 years was 71% for the experimental group. This was higher than the base rate of 56%, but not significantly significant. And then this contradicted all of Leary's claims. So not quite as impressive as Leary wanted it to be. So Peter Hendricks, my mentor at UAB, he did in many ways, like a secondary data analysis of a really large database. So in Alabama, particularly in Birmingham, they have it's called TASC, TASC, and it's in many ways like an alternative to prison. So if you're like a nonviolent offender, you are routed to like a TASC program. And so what he did was he took, because when individuals enter into the TASC program, they have to answer all these demographic and historical questions, where they were looking at serotonergic hallucinogens to see if that how that worked or how that correlated with any sort of supervision failure. So again, instead of in TASC, you have to go and like meet with a probation officer or a counselor, like you have to check in on a however long basis, wherever it's weekly, biweekly, monthly. And then if you miss those check-ins, then you're referred to jail or prison. And so looking at this, one of the elements that they looked at was, have they used serotonergic hallucinogens at any point in their life? And psilocybin was associated with reduced odds of theft, assault, and arrest for property or violent crime, because when that person comes in, they have a whole line of information in the database where they're looking at what was the crime that they committed, what was the referral to TASC. And then another element is, have they ever used serotonergic hallucinogens? So lifetime use of serotonergic hallucinogens showed protective effects against criminal behavior. And the rationale is to reinitiate clinical research in using psilocybin-assisted therapy for antisocial behavior and recidivism. So saying like, all right, let's give this like prison experiment another chance. So future research and conclusion with this section of the chapter: conducting new experiments to address the impact of psilocybin therapy on recidivism rates. It's encouraged. We're gathering some information as to why it should be looked at again. Assessing long-term effects of psilocybin treatment on criminal behavior, and just seeing, what are there treatments that could be helpful with recidivism or with the propensity to commit crime. Further exploration, which I understand it's not just like these are systemic issues as well. I understand that. Further exploring the therapeutic potential of psilocybin-assisted group psychotherapy, because as we learned about last week, it can be extremely expensive. So let's see, like, is it helpful in group settings so that the human resources and the cost of the human resources reduced? So some more future research on examining the role of psilocybin in reducing antisocial behavior and promoting rehabilitation, and a call for continued investigation required to establish the efficacy and safety of psilocybin treatment in criminal recidivism. So some issues related with non-medical use, so recreational use. Psilocybin and classic psychedelics have shown a potential for enriching healthy individuals. Motivations for non-medical use include creativity enhancement, problem solving, and spiritual exploration. Historical contexts provide models for responsible consumption methods, because in many ways, the 50s and 60s were a lot of what not to do in this. Indigenous cultures have restricted psychedelic usage to ceremonial and religious contexts because it's more controlled, because there are safeguards in place. So Indigenous individuals aren't just like handing out like peyote and ayahuasca and psilocybin or psilocybe mushrooms to one another. It's a very controlled environment. And then safeguards for this include preparation, restricted access, guidance, and societal appreciation for the medicine. So as we know, matrix that we learned about in weeks either 1 or 2 is the societal perception of these substances. All right, so risks, there are them, y'all. So non-medical users may overlook the importance of set and setting in their psilocybin experiences. We've talked about that. That's really what leads to that, contributes heavily to a bad trip. If there is a lack of preparation, monitoring, and trained professionals, it increases risk in non-treatment settings. So again, if you're like a concert or at a party and you're unsure and you go into this experience, you're not going to have a good time. You're going to like end up under a table for hours just wanting it to stop. That is not a personal story, but it is one that I've heard many times. Recreational users are less likely to be screened for psychiatric disorders, predisposing them to traumatic experiences, because you might potentiate something, you might experience something that that doesn't make sense, that in many ways can be a traumatizing experience. Psilocybin obtained from recreational settings or the street may contain impurities and contaminants that can negatively interact with the psychedelic, or just not even necessarily in terms of chemically, but like what they do in your body. Combining multiple drugs during a single use occasion can lead to unpredictable effects and crises, like, for example, alcohol and cocaine, when you use them together, creates a byproduct called cocaethylene, which is the #1 reason why people using alcohol and cocaine overdose and die. So very rarely are people actually dying from just cocaine use or just alcohol, but when those chemicals come together, cocaethylene is lethal in small doses. So just so you know, for any of you who do cocaine and go out and drink, you are risking your life every single time. All right, adverse effects and surveys. So psilocybin usage can lead to adverse psychiatric and medical effects, although rates are relatively low compared with any other substance. And like I said, reports include fear, delusional experiences, depression, cognitive disturbances, and physiological symptoms. Dangerous behavior and episodes of violence have been associated with psychedelics in unsafe settings. Again, it's rare, but it happens. So we can't say that this is like a totally, riskless or not dangerous substance. Web-based surveys have captured descriptive rates of adverse effects and experiences with psilocybin. Some of the statistics on that are in the chapter, so make sure to refer to that, where it's still considered a meaningful experience, but also there was risk to self and risk to others. Difficult experiences were common, but many reported meaningful benefits from their psilocybin sessions when set and setting were optimized. So psilocybin, as we know, is a naturally occurring psychedelic compound that's found in certain species of mushrooms. It's been studied for its potential to induce mystical experiences, which it does. The Good Friday experiment in 1962 investigated the effects of psilocybin on religiously oriented trainees. And the participants who received psilocybin reported increased scores on all 8 categories of the mystical experience questionnaire, which I'd covered earlier in the presentation. And then at 6-month follow-up, the psilocybin group showed enduring positive changes in attitude and behavior compared to the control group. So in religious settings and religiously kind of oriented individuals, it is also has been a positive experience. So psilocybin was found to occasion highly religious and meaningful mystical type experiences. The participants continue to report mystical type experiences at a 25-year follow-up. Because at the Johns Hopkins University, they did a replication of the Good Friday experiment and confirmed the positive effects of psilocybin, and participants reported improvements in positive attitudes, mood, altruism, and behavior following the psilocybin administration. So in terms of spirituality, psilocybin has been found to induce highly meaningful and spiritual experiences. In this replication study at Johns Hopkins, psilocybin experiences were rated as substantially significant. Many participants consider the psilocybin experience among the most meaningful experiences in their life. Long-term follow-up studies followed that the psilocybin experiences remained highly meaningful and spiritual. And the Psilocybin Religious Professional Project aims to understand, which is being done at Johns Hopkins, the effects of psilocybin on professional religious leaders, including changes in spirituality, well-being, and pro-social attitudes and behaviors. Like, that's pretty interesting. So to finish up this chapter, I'm going to be talking about each of these applications in more detail in following slides, but just letting you know, these are what I'm going to be covering in the next like 7 slides. So one thing that I realized I haven't really maybe made clear to all of you is what the different phases look like and their purpose. So there are discovery and preclinical trials that then go to phase 4. And after phase 4, that is when it is openly available to the public. So you can see though here that FDA approval is granted after phase 3, before phase 4. So one of the things you can see is the participants, it's small and then it continues to increase with more heterogeneity in the participants. So phase 1 tests an experimental treatment on a small group of often healthy people to judge its safety and side effects to find the correct dosage. In phase 2, this focuses on effectiveness and obtains preliminary data on whether the drug works in people who have a certain disease or condition. Phase 2 is also separated into sometimes A and B. So phase 2A is specifically designed to assess dosing requirements, so how much of the drug should be given, whereas phase 2B is specifically designed to study efficacy, how well the drug works in the prescribed dose. So then phase 3 gathers more information about safety and effectiveness. It studies different populations and dosages and examines use of the drug in a combination with other drugs. And phase 4 happens after FDA approval, monitors safety and effectiveness in a large diverse population, and collects information on long-term side effects. This is also called post-marketing surveillance. So you can see here, I just wanted to provide this to you because you can see here the different purposes of each of the phases as well. All right, so psilocybin treatment, phase 2-3 psilocybin treatment, as I believe phase 2 is happening right now for major depressive disorder. So there's justification for this based on open label trial and 3 RCTs. Compass pathways, which I mentioned in the first, I think the first presentation, which is a for-profit pharmaceutical company out of the UK. It was also in John Oliver's clip that y'all watched. This is a phase 2B trial for treatment-resistant depression. There's a potential for pivotal phase 3 trials. This is comparison with some of ketamine's limitation, because ketamine has abuse liability and its antidepressant effects tend to degrade after 1 to 2 weeks, whereas psilocybin would be a clear advantage over ketamine in terms of both decreased addictive potential and sustained clinical improvements, which is it's ironic to me because psilocybin is a Schedule 1 substance. Ketamine has a known higher abuse liability and it's a Schedule 3. And as we know, it's the only legal psychedelic that is being used. So it's again, all political. But one of the advantages for ketamine is that its active period is only 30 to 50 minutes. So it fits in traditional psychotherapy settings. All right. So phase 3 psilocybin treatment for cancer-related psychiatric distress. These are all what we can do moving forward. So there's promising results from phase 2 trials. We need larger clinical trials to replicate the findings. A multi-center trial design with a nationally representative sample would be beneficial. And then there's the benefits of rapid therapeutic effect and sustained improvements in terms of anxiety and depression, as we've been learning. And addressing existential distress in cancer patients is they're in many ways like an underserved population with this. So addressing this could really be beneficial for individuals at like end of life or who are up against a potentially terminal diagnosis. All right, so phase 2 and 3 psilocybin treatment for alcoholism and tobacco addiction. The trials are like pilot and phase 1 are nearing completion. There's been positive results that would require larger multi-center trials, funding possibilities through private or public-private partnerships. The funding that is available for psychedelics right now is almost exclusively privately funded. I think I said last week that, last month, a federal funding agency had a call for proposals for psychedelics, which is the first since the 60s. A potential pivotal phase 3 trials for the rescheduling of psilocybin. So the hope is that it would move at a minimum to Schedule 2. Then there's uncertainty regarding NIAAA, which is the National Institute on Alcohol Abuse and Alcoholism, and NIDA, the National Institute for Drug Abuse funding. They're still not sure in terms of should we give money to this. It's bitten us in the butt before. So compassionate use, rescheduling, and licensed psychedelic treatment clinics. There's a possibility for compassionate use during phase 3 trials. The potential for rescheduling psilocybin will allow for therapeutic use. FDA's risk evaluation and mitigation strategy, so REMS. The REMS is the FDA would likely require the use of psilocybin to be monitored through its risk evaluation and mitigation strategy program, which can require drug manufacturers to ensure that the benefits of a drug product outweigh its risks. The REMS program is essentially a safety strategy to manage known or potentially serious risks associated with a new drug product and to enable patients to have access to the medication while maintaining safety of the drug. And then another thing that was mentioned in this section that I just wanted to define for you was what off-label means. So an off-label drug use refers to the practice of prescribing a drug for a different purpose than what the FDA approved. This practice is called off-label because the drug is being used in a way not described in its package insert. This insert is known as its label. So just giving you a definition there. And then some other potential clinical applications for psilocybin treatment, the exploration of psilocybin treatment for various addictive disorders, eating disorders such as anorexia nervosa, personality disorders, and the potential benefits of psilocybin with that. PTSD, which again, MDMA is being applied with that primarily, but psilocybin's kind of coming into the scene as well. And then the importance of cautious and tailored approaches. Because right now it's kind of in some ways a one size fits all in terms of the protocols and just seeing, are there different ways for preparation? Are there different ways for integration? Okay, so now let's talk about the long-term follow-up of psilocybin-assisted psychotherapy for psychiatric and existential distress in patients with life-threatening cancer. So a lot of what we were reading about wasn't this long-term follow-up, but okay. Psycho-oncology is increasingly recognizing the unique existential challenges accompanying a cancer diagnosis. Existential distress has been described as mental distress experienced by those facing imminent death and associated with demoralization, absence of purpose or meaning, hopelessness, isolation, and loss of dignity. So just think about this in terms of, this isn't just the patient that's struggling here or that's affected by this, this is their loved ones. So this type of existential distress isn't just felt by the individual, it's felt by nearly everyone in their system. So with this study, it was a long-term follow-up analysis of a randomized placebo-controlled trial that compared a single dose of psilocybin. This is another way of, normally it's 20 to 30 milligrams per 70 kilograms. So just a different way of writing it is 0.3 milligrams per 1 kilogram of weight. With a single dose of niacin, an active placebo, in conjunction with psychotherapy with 29 patients with cancer-related psychiatric and existential distress. So there were two essentially long-term follow-ups that occurred in this, one at 3.2 years and one at 4.5 years, following the participant psilocybin dosing date respectively. So I'm sorry, it was an average. So anywhere from 2.3 years to 5.5 years, with an average of these first and second long-term follow-ups, averaging 3.2 years and 4.5 years. So I just wanted to also give you the participants, there were only 15 participants that were available at long-term follow-up. Several of them passed away, but you can see they were majority women, average age of 53 years old, vast majority were white, and in terms of spirituality, they were kind of all over the board. And then the site of the cancer, with reproductive and other types being the most common. And then the sample was about split in terms of if it was a lower stage cancer, meaning 1 or 2, and then an advanced stage cancer being 3 or 4. And then what they were diagnosed with, primarily adjustment disorder with anxiety, and about half of the participants had never used any hallucinogen, and you can also see a highly educated sample as well. So none of the participants reported lasting negative or adverse effects from the psilocybin treatment, which is important. So clinically significant, like I said, is defined as 50% or greater reduction in a score at a particular assessment point relative to baseline. So this is usually like high scores on the BDA, high scores on any sort of anxiety assessment, that score reduces by 50%, and that's what's considered clinically significant. So you can see here, I want to point out here that the different significance scripts. So A is P equals 0.001, B is P equals 0.01, and C is P equals 0.05. It's less than each of those. So A is very, very significant, B is still significant, and C in many ways is kind of like the lowest threshold for, or the highest threshold of what is considered significant. But you can see these A's and B's and C's all over the place. Obviously nothing's in baseline because that was the first reading, but this was on the hospital anxiety and depression scale, the state trait anxiety inventory, and then other like the Beck depression, and then questions of demoralization, hopelessness, death anxiety, meaning and peace, faith, spiritual well-being. So here with spiritual well-being, social relationships, environmental health, physical health, and psychological health, the hope is that those scores increased, which they did. And then anything from death anxiety and up. So I'm pointing to it like you guys can see my fingers. So from HADS anxiety up until hopelessness, the hope is that those scores went down, up until death anxiety, and then meaning and peace to psychological health, the hope is that those numbers went up, which largely they did. All right, so I just also wanted to give you like a visual representation of the results here. So here, sorry about the cutoff. So anxiety and depression. So you can see at 6.5 to 8 months, huge drops, huge drop, big drop, and then slight increase at 3.2 years, and then a downward trajectory. This has about a plateaued trajectory, slightly upward trajectory, still down. But you can see here with demoralization, that was lower. And then so there's like decreases in every place that you would want, decreases and increases in every place that you'd want. Increased physical health also makes sense of like 4.5 years post psilocybin session, that, maybe just age is getting to them as well. So physical health and psychological health to me also makes sense that they're on a downward trajectory at the follow-ups. All right, so the data suggest, and then just a quick note here, data, that is a plural word. It suggests that psilocybin-assisted psychotherapy is associated with large and significant reductions in anxiety, depression, hopelessness, demoralization, death anxiety, as well as improvements in spiritual well-being at 3.2 and 4.5 years following psilocybin administration after crossover. So this was one of the crossover designs, but they were measuring this after the essentially second group who got the placebo first. And okay, sorry. So let me just lay this out for you. So group A, let's say they got psilocybin first. Group B got the active placebo first. They were doing the measurements at an average of 3.2 years. That may have been earlier in group A because it was after the crossover for group B. So they were still measuring at the same intervals with both groups, but just know that if group B finished their psilocybin 5 months after group A, their follow-ups were starting 5 months later. I hope that made sense. So approximately 60 to 80% of participants continue to meet criteria for clinical antidepressant and anxiolytic response. So reductions in depression, reductions in anxiety, and remission at the second long-term follow-up. At the second long-term follow-up, so average of 4.5 years, participants overwhelmingly attributed subjective experiences of positive changes to the psilocybin-assisted psychotherapy. So given everything else that they experienced over a course of about 5 years, between 71 and 100% of them attributed their positive changes to psilocybin, reporting improved well-being or life satisfaction and rating it among the most personally meaningful or spiritually significant experiences in their life. So existential distress, as I said, is under-recognized and undertreated in cancer patients within Western medicine. And among medical illnesses, depression and hopelessness associated with a diagnosis of cancer can serve as severe stressors and are well-known risk factors for suicidal ideation and completed suicides, as well as decreased quality of life in terms of your immune system is negatively affected by stress. So that could in some ways compromise even the efficacy or effectiveness of your treatment, whatever that is, radiation, chemo, whatever it is. So there's a lot of reasons why treating the existential distress could also improve outcomes with cancer treatment. All right, so last but not least, y'all, the effects of psilocybin-assisted therapy on major depressive disorder, a randomized controlled trial. All right, so purpose of the study. Although many patients with depression showed reduced or remitted symptoms after treatment with existing pharmacotherapies, approximately 30 to 50% of patients did not respond fully, and as many as 10 to 30% of patients were considered treatment resistant, resulting in average effects that were only moderately or modestly larger than the effects of a placebo. My understanding of treatment-resistant depression is that it's you've tried 3 different modalities and you really haven't improved at all. All right, so there's a substantial negative public health impact of major depressive disorder, and it underscores the importance of conducting more research with drugs with rapid and sustained antidepressant effects. Current pharmacotherapies for depression have variable efficacy and unwanted adverse effects, things like lowered libido, weight gain. Novel antidepressants with rapid and sustained effects on mood and cognition could represent a breakthrough in the treatment of depression, and may potentially improve or save lives. So one thing that I did want to explain to y'all, I don't know, y'all didn't necessarily ask for a research class, but I'm going to give you one. So this consort diagram, which stands for the Consolidated Standards of Reporting Trials, I just want to highlight to you how many people are assessed for eligibility in these studies and how many actually happen, how many we actually get in the study and then how many we actually get to follow up with. So 870 people were assessed for eligibility, and then 800 were excluded from the study for various reasons, screening, eligibility, all that kind of stuff. 70 people consented to participate, 43 disqualified for participation for whatever reason. Again, usually maybe they dropped because of time commitment, something else happened. all kinds of reasons. And then 27 were enrolled and they were randomized into a treatment group or a delayed treatment group. And you can see here, even once they're randomized, like in the treatment, in the immediate treatment group, 1 dropped out before session, 14 underwent 1 session, 1 dropped out before their 2nd session, and then 13 ended up attending session 2. So some same things here. So they attended, and then so it ended up with 13 being in the analyzed in the treatment group and 11 being analyzed in the delayed group. So it started with 870 people. And that's the reason why these studies take forever. So maybe this will help explain what I was trying to do earlier in like the follow-up. So for example, like this is when follow-up started with group A, and this in week 13 is when they started in group B. So you can see here with immediate treatment, basically this is 8 weeks when 8 weeks of treatment and all of that stuff. And then at 8 weeks is when the delayed group got a chance to start. So here they were still assessed at the same, because you want to be able to compare these assessments at the same time period. And then you're going to assess again. So you're not only comparing these to each other, but then you're comparing these as well. All right. And then takeaways from this is the last slide, I promise, is although the rapid antidepressant effects of psilocybin are similar to those reported with ketamine, the therapeutic effects are different. Ketamine effects typically last for a few days to 2 weeks, whereas the current study showed that clinically significant antidepressant response to psilocybin persisted for at least 4 weeks, with 75% of participants continuing to show a clinically significant response at a 4-week follow-up. The present trial showed that psilocybin administered in the context of supported psychotherapy, approximately 11 hours of it, produced large, rapid, and sustained antidepressant effects. The effect sizes reported in the study were approximately 2.5 times greater than the effect sizes found in psychotherapy and more than 4 times greater than the effect sizes found in psychopharmacological depression treatment studies. So again, what we have available isn't great. So why not try other things in terms of psychedelics and their application to several different presenting issues? All right, y'all, that is all I have for you. Have a great rest of your week.